Today, you will learn about how our need to modernize is critical and why we must transform the public health enterprise. Whether it's re-emerging vaccine-preventable diseases like measles, emerging infectious diseases such as Ebola or Zika, new threats like e-cigarettes building on old threats, tobacco, prescription drug misuse with addiction driving the opioid epidemic, hurricanes and severe weather, antibiotic-resistant organisms like Candida auris, lead, public health threats are persistent and constantly evolving, here at home and overseas. Protecting our nation's health and defending our health security depends on immediate, geographically specific, population-wide, complete and accurate detection and reporting of diseases and conditions of public health consequence. Effective prevention and rapid, efficient, optimal responses rely on an interactive network of governmental public health agencies at the federal, state, local, tribal, and territorial level, working with healthcare providers and the public. Every day, often unbeknownst to most Americans, public health surveillance is saving lives by detecting and facilitating the responses to health threats. Unfortunately, the nation's public health data systems are antiquated and in dire need of security upgrades. Sluggish processes, like paper records, phone calls, spreadsheets, and faxes requiring manual data entry, are still in widespread use and have significant consequences: delayed detection and response, lost time, lost opportunities, and lost lives. Despite widespread use of technology and dramatic changes in the way that health data is collected, stored, and shared, these data are not flowing seamlessly to or within public health. In this information age, public health departments struggle to meet the public's expectation for life-saving information made immediately available at their fingertips. The data are moving more slowly than the disease. In a world where anyone can go anywhere to any other place on Earth within 36 hours, the demands for disease surveillance have changed dramatically from even 20 years ago. Today, the health of every American is at threat from emerging diseases everywhere around the world. This reality demands a new national health security mindset and approach. Simply stated, we must reduce the interval between recognition of a problem and the response to it. Shrinking that time interval in today's information age requires an enterprise approach, investment in durable information infrastructure of data scientists, information technologies, and an enabling policy structure. Traditionally, we have really taken a more disease-specific or piecemeal approach to our surveillance efforts. And while progress has been made in this siloed, fragmented approach, we need to take a more transformative enterprise approach, a holistic approach, and a robust, sustained commitment to transform today's public health data system and leave a lasting impact on America's health. To really move public health into the 21st century, we need a big, bold, coordinated initiative. We simply cannot keep doing the same thing and expecting different results. The technology is available to develop the enterprise public health data superhighway, but new, consistent, reliable, and sustained investments are needed to improve the health of the nation. We need to modernize in a way that empowers public health to be a full partner in protecting society. By taking an enterprise approach, we will connect data and data systems in seamless, interoperable ways to achieve real-time flow of information. Connecting our data together in ways that rapidly identifies and predicts problems rather than merely waiting to respond. Today's analytic and diagnostic technologies make this possible. And we need sustained funding because the digital roads will wear over time. They need to be repaved on a regular basis. The data the systems provide are only as good as the people who can access and use it. It's about data and workforce. Thus, our enterprise approach must account for data and system transformation and support efforts to modernize the public health workforce. To ensure we have the right, highly skilled people to use the systems, maintain them, interpret the data, and develop and deploy actionable interventions. We need to see public health serve the public the way the public wants and needs. There is no human endeavor that is outside the realm of public health or its impact on the arc of the human life. That's why CSTE, APHL, HIMSS, and NAPHSIS, together with more than 90 other entities representing patients and consumers, healthcare providers, public health professionals, and IT vendors, are calling on Congress to provide $1 billion over 10 years to modernize. And lawmakers are listening. Last week, the House passed appropriations legislation that includes $1 million in new funding for a multi-year initiative to modernize the public health data infrastructure. And the Lift America Act would authorize those activities. In the Senate, Senators Kane, Isaacson, and King have introduced the Saving Lives Through Better Data Act that would authorize $100 million per year for data and systems modernization. And yesterday, the HELP Committee reported out the Lower Healthcare Cost Act, which includes similar provisions. Our speakers today will share their perspectives on why more, better, faster data is needed for public health and how we will build this 21st century data superhighway. First, you will hear from Christian Lillis, Executive Director of the Peggy Lillis Foundation. Then, Dr. Joanne Barticus, the Director of the Minnesota Public Health Laboratory. And finally, we are very excited today to have Dr. Ann Schuckett, Principal Deputy Director of the Centers for Disease Control and Prevention. We'll have time for questions and answers at the end. And before I turn it over to Christian, I'd like to take this opportunity to thank Senator Richard Blumenthal for helping us organize this briefing, and for APHL, the Association of Public Health Laboratories, for hosting this event. And of course, feel free, please, to live tweet using hashtag #DataElemental or hashtag data, hashtag elemental to health. Let's please welcome Christian Lillis.
I usually say no applause, just throw money. Sorry, 20 years of being a fundraiser. So as Janet said, I'm the co-founder with my brother and the executive director of the Peggy Lillis Foundation, which was named after my mother, who passed away from a Clostridium difficile infection in April of 2010. And I will get into all the details of that in a second. But I wanted to start by saying that most Americans only think about public health or infectious diseases when there is news of an outbreak, or they or a loved one are stricken by one. For myself, coming out as a gay man in New York City in 1989, I was more concerned than the average person, but almost exclusively about AIDS. From the end of high school and through college, I marched, protested, and educated. But as retrovirals made HIV a manageable disease for my demographic, that too receded from my everyday thoughts. While I cared about access to the cocktail for poor and working class people with HIV, I mostly just voted for the people I thought would ensure those policies were in place. That irrevocably changed in April 2010 when my 56-year-old mother, Peggy, died from a community-acquired C. difficile infection. So I want to tell you about my mother, what happened to her, and why I and the Peggy Lillis Foundation greatly support increased investment in our public health data infrastructure. So my mother was born Margaret Mary Daly on October 29, 1953 in Brooklyn, New York. She was the daughter of James and Dorothy Daly. Her father was a World War II veteran who became a bus driver, and her mother worked for the phone company as a switchboard operator. Yep. Does anyone remember what a switchboard operator is in this crowd? After the war, they married, and Mom was the third of their 9 children. So, like most Irish Catholic men, I was raised to believe my mother was a saint. My mother encouraged this myth. When we asked where babies came from, Mom said she had the Immaculate Conception, twice. Seriously, Mom was a 19-year-old high school dropout when she had me. Her and my father did the right thing by getting married. 3 years later, she had my brother Liam. But like many shotgun marriages, theirs didn't last. By the time I was 6, Mom was a single parent, raising us with little assistance from our father. But she persevered. First, she got her GED, then she put herself through college, waiting tables to make ends meet. It took her a long time to finish her degrees, but she started working for the New York Public Schools in her 30s and ultimately became a kindergarten teacher. All through our lives, most of our friends considered Mom to be their second mother. Our tiny apartment was full of teens and young adults who needed a place to crash or advice or a cab fare home. And Mom was committed to us being successful, to avoiding the mistakes she felt she had made. So she helped me she helped put me through college. I was the first person ever with a bachelor's degree in our family, and she was the second. And my brother became a plumber, who now works for Kings County Hospital in Brooklyn. So at 56, my mother's life wasn't perfect, but both of her sons were compassionate, hardworking, tax-paying citizens in stable, long-term relationships. She and my brother had recently bought a house, which helped fulfill her dream of being a homeowner. And several years earlier, her longtime boyfriend moved to Maui for work, so she visited him 2 or 3 times a year. Not a bad gig for a kindergarten teacher. Mom was also the favorite aunt of my 18 first cousins and was deeply involved with her students and colleagues. But that wonderfully imperfect life was cut short in April 2010 by a community-acquired C. diff infection. It started with Mom's longtime dentist prescribing her clindamycin prophylactically after a root canal. 5 days into the course, Mom woke in the middle of the night with urgent diarrhea. First, she assumed she caught a bug from one of her students. She ended up taking a day off. When the symptoms persisted through Saturday, she called her primary care doctor. Without seeing or examining her, the doctor phoned in a prescription for an antidiarrheal. Mom took that and continued to take the antibiotic. When she failed to improve by Monday, her doctor made an appointment for her to see a gastroenterologist. So on Tuesday, April 20th, I arrived at my mother's house, ironically from the dentist myself, to take her to her GI appointment. She seemed really pale and weak, not quite herself, and so we decided that we should instead just go to the hospital. And we called 911. And when the EMTs arrived to take her, they discovered that despite her being up, walking, and talking, her blood pressure was very low. It was like 65/40. So we went to the hospital. Shortly after we arrived, the ER physicians determined Mom had a massive infection. Her white blood cell count was over 40,000, which is very high. The ID attending told us that they thought Mom had a Clostridium difficile infection, which we had never heard of, and that it was precipitated by her using antibiotics. Despite being lucid and assuring us that she is fine, Mom is actually in septic shock. They began fluid and IV therapy, antibiotic therapy. We called our family to let them know how sick Mom was. The doctors performed additional blood tests, scheduled Mom for a CT scan, and performed a colonoscopy to determine if she had an obstruction. She was sedated and intubated to ensure her airway wasn't compromised. They told us that if she didn't respond by morning, they would remove her colon in an attempt to save her life. It was at this point that we realized that what we initially thought was the flu only 4 days ago could be fatal. The doctors told us to go home and get some rest. Sorry, I can't help it. It's hard to tell this story and not try to find some jokes in it. And my mother would appreciate the jokes. So we went back to my brother's house to sleep and cry and pray. At 6 o'clock the next morning, the surgeon called and told us Mom had not improved overnight. They wanted to perform a colectomy in a last-ditch effort to save her. She remained unstable, and so the doctor was afraid she might not survive the surgery, but they were certain she would die from sepsis without it. We consented to the surgery, which Mom survived. I'm sometimes critical of hospitals, but I want to say this little hospital, which I won't name, but it was a small hospital in Brooklyn, they did everything they could to save my mother's life. Like, they had consults from Mount Sinai and NYU, and I mean, it was, so anyway. So when I later get to talking smack about hospitals, from late morning until the afternoon, she seemed to improve, but around 4 p.m. her vital signs began to deteriorate. The doctors put on 100% oxygen and provided additional blood pressure support, but it didn't really work. So between our large family and Mom's close friends, we had about 50 people standing vigil outside the ICU at this hospital. We took turns going in 2 at a time to encourage her to keep fighting, to ensure her that she was strong and that she could beat this. Around 6:30, my aunts were asked to leave the ICU so nurses could help her. About 30 minutes later, the the ICU attending came into the waiting area and said, "Peggy has passed." He told us they had tried to resuscitate her. Her many friends. It felt like all of Brooklyn was in mourning. Her death rippled out into the community, to all her friends at the beach club, to her students' parents, and in subsequent years to all the students who would never have her as their kindergarten teacher. Recently, the last kid she had for a full term, not the year she died in, graduated and was the valedictorian, and said that my mother is who made him have a love of learning. So more than 500 people attended my mother's funeral, causing her friend to remark that a local church isn't even that crowded on Christmas Eve. In part to give meaning to our enormous grief, we needed to understand what happened to her. I went into research mode, reading everything I could about C. diff infections. Most of what I found said C. diff impacted only the elderly and immune-suppressed people who had been recently hospitalized. Mom was neither. In fact, she hadn't been hospitalized since she gave birth to my brother in 1976. We learned that the CDC then estimated that C. diff killed 14,000 Americans every year, a mind-boggling number that exceeded AIDS or drunk driving. Thanks to the research at CDC, that number has since been updated. We now know that about 29,000 deaths occur where C. diff is either the direct or contributing cause. This is an astonishing number of people dying from preventable infections. In the weeks after Mom's death, we learned of 3 other people in our neighborhood who had also recently died from C. diff. So we went from losing our mother to disease we'd never heard of to her being the 4th death in our community in a brief period of time. This is what inspired us to start the Peggy Lillis Foundation. Initially, our goal was just to raise awareness and educate the public, but over the first 3 years, we began to appreciate the structural and systemic causes of these epidemics. Back in 2010, New York State had just begun reporting C. diff infections under its HAI law, and gaps still remain. My mother's death certificate doesn't say C. diff anywhere. And over the years, we've seen that there's enormous variation in whether or not a specific infection is mentioned as the cause of death. Similarly, while we do have reporting of hospital-associated antibiotic-resistant infections, most outpatient and nursing home infections are not reported. And when they are, it's voluntarily. I can't tell you how much this angers and frustrates me. We're the richest country on the earth, and we can't track preventable infections. That's why I support this initiative. Our friends at the CDC and in state health departments are doing an incredible job with woefully inadequate funding. And at the state level, as Janet mentioned, often archaic data systems. In both cases, this is due to a lack of public investment. According to the Trust for America's Health, overall public health spending at the state level has remained flat since 2010. Flat. In that same period, the threat of antimicrobial resistant infections, measles and whooping cough outbreaks, and new disease threats like Candida auris, I feel like I'm stealing your act, Janet, have grown. For many of these infectious diseases, the full burden can only be appreciated retrospectively. That is too late for people like my mother. I often wonder, had we been investing in public health data back in 2006, 2007, 2008, might the other people who died in her community served as a warning? Might there have been an alert to doctors? Might she still be alive? We cannot have 21st century healthcare with a public health system stuck in the 1970s. Right now, I could take out my smartphone and broadcast this briefing live to Instagram, to the entire world. I can take out my computer and remotely access my organization's accounting software. Many doctors can log on to their facility's electronic medical records and check on a patient's vitals. Rural hospitals are using Skype to get infectious disease consults. So technology is not the problem here. Political will is the problem. Healthcare facilities sometimes cite financial costs and staff time as a reason not to publicly report their infections. That's not a great argument. We spend more money in both real terms and per capita than any other country. There's plenty of money and smart people to do these jobs. But really, issues with interoperability of systems is a burden that can be relieved. So now the big one, cost. Most people cannot fathom what $1 billion looks like. I mean, I'd like to. I'd like to fill this room with it. I'd be darling at it. So in April, we had a lobby day for C. diff advocates, and most of our advocates are middle or working class people. They will never see $1 billion, but certainly it sounds like a lot of money to them. It took some coaching to get them comfortable with asking their legislators to increase spending by hundreds of millions of dollars. But in the context of our healthcare spending, $3.6 trillion, it's a pittance. And as part of our $4.7 trillion federal budget, $100 million a year is a rounding error. I actually tried to figure out the percentage. And it's essentially the pocket change you'll find in your couch cushions when you go home today. So money is also not the problem. We don't need to find a pay for or figure out what to cut to provide this funding. What we have to do is demand that our elected officials commit these resources, the ones that are necessary to modernize our public health data systems. Budgets are moral documents. That's a phrase most often attributed to Martin Luther King, and it's something I believe deeply. How our country decides to spend its enormous wealth is a moral decision, not a technical one. My mother became a teacher because she loved children and knew that knowledge is power. With knowledge, we can make good decisions about how to deploy and how to use our public health resources. We can save lives. We have a moral duty to record this harm and to accurately report it and do so as quickly as possible, so that our fellow citizens' suffering is not in vain, and so that we can use that information to better combat these diseases. That's why we started Peggy Lillis Foundation and why we need to provide the resources to bring public health data into the 21st century. Thank you.
I can probably save us a lot of time by just saying what they said. That's good enough. I'm Joanne Barkus. I'm the laboratory director in the state of Minnesota. I'm also the president of the Association of Public Health Laboratories for the next 3 days. And then we'll turn it over to the great state of Texas. A lot of the background information that I could provide to you has already been provided by the other speakers. What I will say is that my former boss, Ed Ellinger, who was the Commissioner of Health in Minnesota, frequently said, data are the coins of public health. And those coins need to be spent wisely. But they need to get to the people that need those coins or need that data and can actually act on it. So let me tell you a little bit about public health laboratories and our perspective on data. So if you're not aware, public health laboratories conduct testing in a number of different areas. Newborn screening, virtually every child in the United States is screened by public health laboratories for a variety of heritable and congenital disorders that are treatable. Infectious disease testing is done in public health laboratories to detect outbreaks, monitor disease trends, including antimicrobial resistance. There's an antimicrobial resistance laboratory network that's funded by the CDC. We assess the efficacy of public health interventions. Have we stopped the spread of disease? And we respond to emerging infections, including Ebola and Zika virus and whatever is coming down the pipeline. We also do environmental testing and providing data to ensure safe drinking water, for example, the stuff that comes out of your tap, that's hopefully tested and safe. We identify chemical hazards in the environment, and we also look for chemical exposures directly in people using a process that we refer to as biomonitoring. And we would respond also to chemical emergencies, just as there's an infectious disease emergency, sometimes there's a chemical emergency. So public health laboratories do a variety of different kinds of testing. And because of the variety of things that we do, we get data and specimens from a whole bunch of different areas. We get them from public water supplies. We get specimens from hospitals, from birthing centers. We conduct different kinds of tests, and we report results to different partners, including the Centers for Disease Control, directly to the submitters. We provide data for a variety of different purposes, which poses challenges because we're dealing with multiple different data systems, all for public health, but dealing with very different data. In addition to those challenges, the evolving technologies have changed the way that data is collected, analyzed, and communicated. And while we have these different systems, a lot of them, if you think about using the analogy of a data superhighway, we've all built roads. Sometimes we've got just a driveway, but sometimes we have a road, but my road maybe doesn't connect to Janet's house, and yet I need to get my data to her house. And then what ends up happening is we have to build a separate road. But then I find out I have to send data to Christian's house, and now I have to build a different road. So it's very disjointed, and it's difficult to get data to where we need to get it. And in addition to that, we're generating a lot more data than we used to. For example, we are doing whole genome sequencing on bacteria, which is generating terabytes of data that needs to be transmitted and communicated in a different way. We can't take that data and condense it into one line on a spreadsheet. So we need data visualization tools. We have to learn not only to produce data differently, but to look at it differently. We also do high-resolution mass spectrometry. So for example, for the opioid crisis that's ongoing now, we're now doing a different kind of mass spectrometry that's generating even more data than the whole genome sequencing. And now we have to get that to a different group of partners. So there's a lot of challenges here, but there's also a lot of opportunities. So the opportunity is, as has been mentioned, to create an overarching infrastructure that will enable us to transmit data more readily. So some of our opportunities, for example, are, and you've already heard, manual data entry is a problem. And I'm going to give you an example that I stole actually from the state of Indiana when they had their first and only, I believe, MERS coronavirus case, the Middle Eastern Respiratory Syndrome virus. The state public health laboratory was able to test for MERS, but the specimens they were getting came with paper that had to be manually entered. So is there technology to enable us to do electronic test ordering and reporting? Yes. Did the clinical laboratories, did they have that in place? Yes. But it wasn't used routinely because of resource issues and because of training and because people forgot all their passwords. I know that would never, no, seriously, that's the truth. They forgot their passwords. And then you need somebody to help them, then they have to reset their passwords. By the time you do that, it's kind of easier to do a piece of paper. So we really need these plug-and-play systems that will enable us to make utilization of the technologies that exist. The difficulties in reporting have also led to underreporting of diseases, and that's already been alluded to. I was at a meeting a few weeks ago and I heard Lyle Peterson from the CDC's vector-borne disease division talking about underreporting of vector-borne diseases. It's underreported anywhere from 8-fold to 40-fold depending on the disease that you're talking about. And there are some states that have actually stopped reporting Lyme disease. And I won't name the states, but somewhere out in the east where Lyme disease is quite prevalent because it's too burdensome to try and report that manually. So we don't even know how much disease is going on, even though we do know with the data that is reported that vector-borne diseases are increasing, but we're only seeing the tip of the iceberg. We also need to work on our analytical workforce. This also has been alluded to. These new technologies that we're using in the laboratory are generating big data. And I know you've heard about big data, the challenges with big data. It's not just big data. Little data is problematic as well. But we need to have a specialized workforce, both in the laboratory, to do the testing, to analyze the results. And then the folks that are interpreting that data need to have specialized skills as well to be able to visualize it and use it to its full capacity. So things have gotten better. We no longer receive paper reports from CDC. We get emails. And it's better than it was. We can take a PDF and attach it to one of our electronic files. But it would still be nice to be able to do that seamlessly electronically. So we're moving forward, we're just moving slowly. Data that we get sometimes have different fields required. We have no standardization of our language, right? We're speaking different languages, we need different fields. So in the laboratory, we have information systems where we plug in our data, but they're designed for the most part for clinical laboratories, and we are receiving and collecting different data. And an example I will give is that we need county information. The hospitals don't really care about that. They don't have that in their system. The LIMS, Laboratory Information Management Systems, that are created for clinical labs don't even have a field for county. So we are a year delayed, actually, year plus, in implementing our new LIMS because the vendor has to customize it for all of pretty much everything that we do. And the data terminology doesn't even exist. In public health laboratories, we do a different kind of testing than clinical labs do. We're looking at things from a population basis. So some of the tests we do, for example, for measles typing, right? It's not just does somebody have measles or do they not? Is it the vaccine strain of measles or is it a wild type? And those are two very different things. Well, there's no terminology, no what are called LOINC or SNOMED codes for measles typing. APHL is working on fixing that, but you know, we need to do this more globally. What I'm going to do next is try to wrap up so that I can give Dr. Schuchat plenty of time. What I want to say is that data is most useful if it's combined with other data. And there are a lot of data sets that are existing in the Minnesota Department of Health, for example. We have a data inventory, and we have more than 370 different data sets, and they don't talk to each other. So we need that standardization. We need that interoperability to make these systems more useful. So I'm going to close by saying that our need for data is dynamic, but the systems that we have in place were created for static data that's just sitting in one place. We have the opportunity now to fix that and to fix it in a big way. When I was putting this presentation together, I tried to organize the thoughts in buckets of reporting and data analysis, but they're all interrelated. And in order to fix the system, you have to fix it globally, not just piecemeal. When we have another pandemic or another disease outbreak, it's going to happen fast, and our data has to happen fast as well. So in closing, Edward Deming said, without data, you're just another person with an opinion. But Forbes magazine said without an opinion, you're just another person with data. And so what we need to do is marry those two for public health purposes. Thank you.
Well, it's a real pleasure to be part of this session, and I hope people aren't too depressed about the state of public health data, because I do think this is a very optimistic moment. First, I just want to thank the partners who put the briefing together and have been doing an incredible job of raising awareness of where we are. I think the American public would be absolutely shocked to know the status of data capacities in the public health system, including at the CDC, which some of us think should be ahead of everyone. And I also want to thank the staffers who are here and the incredible interest that we've seen. You know, Christian began this by talking about, I think, his grandmother, who was a switchboard operator. And I would say probably every single person in this room has a smartphone in their pocket. Public health is at the switchboard era. I mean, it's true. Okay, and it's, you know, I've been in this system for 31 years, and it's really embarrassing. We, the United States of America, has the technology. This is not a technology gap. Public health doesn't have it yet in a widespread, holistic, coordinated, strategic way. The technology alone is not going to fix this problem. We all know garbage in, garbage out. You need technical expertise in public health. This is not just an IT fix by yourself, everything that looks very bright and shiny. But if we can link public health expertise with the technology, the American public will benefit, and we can, in the long run, save lives and money and improve health. We want to reduce the burden on the healthcare providers who report data and reduce the burden on the public who answers surveys, and save lives by getting the right information where it needs to be interpreted at the right time. And that takes strategic, holistic investment. We have a little handout that I'm just going to hold up, which is kind of the world where we are right now and where we want to be. And that, you know, I hope you'll take it as you leave, really moving from a reactive system to a predictive system, an efficient system is what we really need. And I think there's been a lot of great work on strategy. This isn't sort of the same old thing from 20 years ago about if we just put a lot of money in this, everything will work. This is a complex issue, but the world has really changed, and I think we're at a point right now where this is the right time to invest. If we don't invest now, it will be too late. If we invest now in a random, not coordinated way, we will get nowhere. But we have the right tools and the right, I think, community to put this together. There was a comment from Joanne about the buckets, and I think a lot of us who are not IT people struggle figuring out what are the buckets here, and, you know, how can we group this in a way that we'll get where we want to go. I want to give you two options for buckets. Okay, the first bucket option is to think about the universe in terms of where we want to go in three broad buckets. And one is modernized technology and public health capability, which is kind of the stuff and the systems. A second is the public health workforce. And a third is innovation. The first idea is, you know, we need the system, the investment in the infrastructure that will connect all these separate parts. We need the platforms and the capacities and standards and you know, privacy protection and all of that. But we also need a workforce that knows how to work with data and how to connect that with the public health needs, whether it's contact tracing or laboratory reporting or monitoring the impact of interventions on antimicrobial resistance. But we also need innovation, because if all we do is invest in infrastructure, it's not going to keep pace with the opportunities and the needs and the threats that we have. So those three broad buckets are how CDC is thinking of the way that we would envision using resources. But the other bucket category I wanted to share was this idea of the environment in four different ways. And I just heard this yesterday from a brilliant Georgia Tech data scientist, but he kind of groups the universe right now into 4 buckets. Big data bigger than ever, whether it's hospital data or whole genome sequence data or environmental data or drug data. Big analytics, the ability to use those data, as we've seen successfully with influenza, with AMD, with some of the opioid work, but it's piecemeal, and we need the big analytics to keep pace with the size of the data. But the third thing he points out is what he calls big interoperability. It's jargon, but his read of the universe is that the healthcare system, the hospital system, is there because of the way investments were made. They're interoperable enabled. They may not all be using it, but they have the interfaces that let them connect the healthcare data with each other or with the state or with payers. And his view was that the payers have required this, so the system is there now. And the fourth category is big community. And this is really the workforce. And this, I'm seeing half the people in this room are way younger than me. There has never been so much interest in young people in public health as there is today. And there has never been as data-enabled a young population as there is today. And the data scientists of the future and the public health experts of the future can be the reality of this data era that we live in, but we can't disappoint them. We can't get all these public health grads coming to state health departments, local health departments, CDC, and seeing the shock of our data systems. The other thing that Dr. Duke from Georgia Tech confirmed yesterday was the idea that this can't be top-down only or bottom-up only. Because if it's not both, we will not get where we want to be. We need leadership commitment and holistic strategic investment that is partially top-down so that we don't invest in this silo and get flu and opioids where we need to be, but not everything else. If we don't invest in grassroots innovation, we will not get beyond where we are today. And there's extraordinary progress going on, whether it's machine-based learning and artificial intelligence and things that can take all those record reviews we do manually and make really good sense out of it. So we also need to invest in innovation and invest in the grassroots, but we need to connect them. And that's why I'm so gratified at the partners really pulling together to think about this, not as my disease or my lab or my jurisdiction, but as a community. And so I do think as a community, public and private, we can get where we need to go. So I want to leave some time for questions and just leave you with that idea that it's going to take a big community working strategically on this issue, but we no longer have a question of is there a need? There's an enormous need. And we no longer have a question of what do we need to do? There's a strategy. What we have to do is take that need and that strategy and marry it with resources and committed, coordinated investment. So thank you.